So once upon a time in High Point, North Carolina in 1993, a group of 7 doctors got together because they thought that the Clinton health plan was going to come in and take over health care, and that we were all going to go to socialized medicine. And we didn't have any particular understanding of how we, as a bunch of little independent practices, mostly specialty, with some primary care that wasn't seeming to be able to recruit anybody, could make it in that world. And so we formed a multi-specialty group called Cornerstone HealthCare that was 16 practices with 42 physicians, about half primary care and about half specialty, and said, let's see what we can do in the world we're in. And it was the fee-for-service world, and we killed it. We did great. We have had outrageously good contracts, and we have grown, and we have ancillaries, and we're big, and we're 342 providers, 240 physicians on staff at 15 hospitals that are part of 8 health systems in the Piedmont Triad region of North Carolina, expanding as far as Asheboro to Hickory, a 2-hour drive between them, over the last 18 years. But we don't think that we will even be here 5 years from now if we keep doing that, because we think that that's an unsustainable system, as I talked before. So Cornerstone's physicians really started thinking about what we needed to do to move to where we wanted to be in the future. We thought there was a strategic imperative that if we could figure out how to do this value thing that we're talking about within the context of our, at that time, 60% specialist, and that if we could really understand what a physician-led independent company could do that wasn't affiliated with just one hospital, that we might actually be able to fulfill some strategic long-term goals, which was to have a return on investment for all the blood, sweat, and tears and work that we've done to build our organization over the last 18 years, to create an environment where it really makes it enjoyable to practice medicine the way we all went to medical school to practice, and to provide some financial stability to our docs during a very uncertain period of time. So about 2 to 3 years ago, we started looking around at our options, and we said, well, we could just keep doing what we've been doing, and we thought that would last about 5 years, and then we'd probably be some big trophy on some big integrated health systems trophy shelf. That wasn't part of our cultural values. We could sell ourselves, and we think we looked at that, we think we'd probably get a pretty good value for us. We could partner with other organizations, and we're doing that, and you'll hear about that a little bit. We could redefine our business model and become a very, very highly efficient provider of services to a healthcare population management hub, or we could become the population health management hub. And so that's what we decided to do. And about 2 years ago, the physicians in Cornerstone decided to stake our future on this. We have borrowed or are borrowing $25 million, putting ourselves completely, our company's very livelihood at risk, to basically say that we believe that we will get and become a population health management hub and be able to provide a sustainable, highly effective, high-quality, low-cost health care in our area. So we saw it as being a 5-pronged thing. Part of it is the Cornerstone Cookbook is the underlying base of the medical home, as well as clinical integration. This isn't about just primary care, as been said by the other specialists. It's about getting everybody on board, hospitalists, SNFs, the whole 9 yards together. It's about information integration in ways that are far more than just electronic records or claims. It's about organizational realignment. You've got to really, really change what you're doing. And it's about reimbursement model transformation. You cannot do this halfway, stick your toe into it. You're going to have to go all the way, at least that's the way we see it. So the first thing we started working on was the medical home. About 5 years ago, we built a couple of large buildings where we could consolidate a lot of practices and services and run them 7 days a week, not just primary care, but ancillaries, imaging, and some of our specialty services that would help lower the cost of care by keeping people out of the emergency room. This includes a 7-day-a-week infusion center, not to make money off of giving chemo or Remicade or anything like that, but giving Medicare patients drugs such as IV fluids on the weekend so that they're not hospitalized. We created a very robust medical home, which included clinical pharmacy services, the integrated weekend hours. We educated all our 1,700 employees as to what that meant, and also started very early with the concept of outreach with what's called our patient care advocates. Our Chief Medical Officer, Dr. John Walker, is in the audience, and he basically decided that if we took some of the information we had and found those patients with some of our analytic tools who were diabetic with a hemoglobin A1C, a blood pressure, or an LDL cholesterol that was not under control, that hadn't seen their doctor, their primary care doctor, in the last 6 months, and just called them up and invited them to come back to visit us, that we might be able to start making an impact. So our $13 an hour employees have done a whole lot better than our endocrinologists in certain aspect of things, and we've been able to make a huge impact with just some very, very early things. When it comes to clinical integration, remember that 62% of all the costs in health care are on the provider side in the hospitals and the physician services, and that you're not going to get where you need to go just by doing generic drugs and cutting the nursing homes or the home health centers. It's going to come out of our hide, and we're going to have to work together to do this. And so we see clinical integration as being about hospital specialists and primary care working together on the things that we all do well and the things that we do separately, that if we do together, we can really start looking and driving the cost of care out. So let me tell you about 3 things that we're doing right now that are a little bit more than just medical home. In cardiology, we have completely redesigned it. We have taken our 300 sickest heart failure patients and have built a clinic around them that's a team-based clinic where we have a psychologist, a social worker, a pharmacist, a team of nurse practitioners that are being supervised by our cardiologist in a clinic that is keeping folks out of the hospital. Our first patient in this clinic had been in the hospital 15 times between January and July this year with their class 4 heart failure. And I don't believe, Dr. Walker, that they've been in since then. Our oncology practice is a new clinically integrated model. So we have those same services, including a breast care pathway, a lung cancer pathway, pathways for all the extensive oncologies that are also embedded with services that involve social work, pastoral care. And also in both of these service lines, we have a co-management agreement with a hospital. We are completely destroying the concept of primary care. I never liked it anyway. When I was in med school, I used to be an internist. Primary care had to do with a copay. The specialists are now being called proceduralists. They're getting ready to whack you too. And hospitalists had to do with DRG. So when they change your name, they're changing the way they pay you. We think that we need to change the concept of primary care and look at those patients who need more than a 15-minute office visit. So we've developed some C5 clinics where we have now dedicated 3 and soon to be more in all of our communities primary care practices just to take care of the sickest of our polychronic patients. Conrad and I used to call these the Hondas in medical school, the hypertensive, obese, non-compliant, diabetic adult. I am a Hondologist. And we're actually creating clinics that are embedded with this same model that's very, very, very robust. We think that we can have some tremendous positive aspects on patient care and already are. We're not stopping there. We've redesigned all of our practices in the service lines, and our doctors are together deciding the top 3 things they're working on this year to save money and to do a better job with care. The final piece that you keep hearing about is information integration, and it's more than an EMR. You're going to have tools with patient engagement and referral management, understanding medication adherence, and how to put evidence-based medicine into your system. The truth is, though, there's no magic tool out there to do that. There are many tools, and we're looking at what is best in class and best in market right now and putting it together into a comprehensive approach that will have clinical benchmarking, clinical decision support, and all those things that it's going to require for us to put together something until the information technology industry catches up with what we need in healthcare. They will, because as the incentives change, they won't just be giving us practice management systems so we can bill and collect. They won't be just giving us EMR so that we can do episodic care. They'll be giving us population health management tools. Right now we're investing in what's out there, but it's an immature industry. We're taking what we have and we're creating some integrated platforms to really look at how we can drill down the cost of care. But that's not where we're stopping. We're going to some places very quickly, as fast as we can. We believe that for physician organizations to be successful, there's going to be several indicators for success in the future. And one is scale. And Cornerstone is large, and we do not believe that we need to be a statewide organization. We do believe we might need to get a little bit bigger in the Piedmont Triad from a risk basis. We're about 13% of the market share. We think it would be better possibly to be able to drive the cost down if we were a little larger. It's got to be about an entire delivery system. It's also got to be about patient engagement, and we're going to get our patients involved in ways through telemonitoring and other things that we're not doing before. Eventually, we will have to adopt risk. I'm not talking about Cornerstone, I'm talking about everybody in this room. The reason we're in the situation that we're in right now is because we haven't been taking risk. The federal government's been taking risks, the state government's been taking risks, the employers have been taking risks, but that's not been our model, and we're going to have to do that, and they're going to make us do it. We're going to have strategic partnerships, and we're going to have very, very advanced technology and infrastructure. This is Cornerstone's chessboard. It's our chess integration bus. We're creating a complex information system where we're taking what sources of information we think are out there and creating an integrated platform with a data warehouse to create some best-in-class tools that we believe is going to allow us to have some far better outcomes-oriented solutions going forward. So as we're redesigning patient care in ways that you've seen some early results on with oncology, cardiology, and our C5 clinics, we're also very, very busy putting every single one of those fantastic little fat fee-for-service contracts we've got at risk right now. And we're doing it by basically taking a gain-sharing approach for 2 years with the concept of going to full risk once we learn what we're doing and get better at our care models, because it's about changing the way you practice. It's not just about contracts, otherwise that's just moving money from one person's pocket to the other. It doesn't get the cost out. So we have nearly all of our payers now, and will have by January 1st, 2013, in some sort of value-based contract. So we've been part of the Cigna National Collaborative Care Network, as is key IPA in this state. We were told we are already 4th best in our recent cost data with them nationally. We're part of an Aetna network. We have something announced with Blue Cross pending, as well as United. We have all of our Medicare Advantage contracts now flipped from fee-for-service to fee-for-value, and you heard earlier we were part of the Medicare Shared Savings Program. We started a narrowed network product this week with Coventry WellPath, and we did that in partnership with High Point Regional as well as Randolph, so that patients have a choice of going wherever they want to, but if they happen to use a Cornerstone and our partners in that narrowed network, they'll get far better benefit on their premium structure, and we announced that to an employer group just this recently. So we're changing our facilities, our information. We're hiring lots of new folks, navigators, care coordinators, health coaches. Dr. Walker comes up with a new name for these people every day. I don't even know who they are. We're running out of room to put them everywhere. But it's really becoming quite a fun ride. We're drinking from a fire hose, but it's a tasty little fire hose, because what we're doing is, what I think we all need to be doing is looking towards our future. So when you're thinking about where you need to be going, we think that there's about 9 things that have to be part of an ACO structure in whatever place that you're in there, whether it's a small primary care practice, part of an integrated delivery network, a multi-specialty group. And that includes network development and support, structure and governance, patient engagement, quality, innovation. We're going to have to invent this future we're all going to. Care transformation, the informatics I've talked about. Lots of people you didn't think were that you used to call corporate overhead or overhead in your practice in the fee-for-service world. And you're going to have the ability to do complex financial analysis and reporting. And you're going to have access to claims. And our contracts now give us access to those claims. I don't actually think that the insurance companies are the enemy or the hospitals are the enemy or anybody else is the enemy out there. I don't think the federal government is the enemy. I think everybody wakes up from their perspective with a white hat on every morning from their perspective, and where we need to go is getting it together. So I want you to end, at least my part here, thinking about the types of competencies you're going to have in a new system for population health management, ACOs, value-based care, whatever you want to call it. And it's going to be care coordination and business development and clinical performance management, things you haven't thought about. You studied the Krebs cycle to get to medical school. When in medical school, you were doing those coagulation pathways and all that other junk. But what we've actually got to think about now is very, very different. It's systems approach, and it's different than we're trained. But we believe that physician leadership will get us where we need to go. Let me end by telling you that Cornerstone has formed a separate company called CHESS, Cornerstone Health Enablement Strategic Solutions, and we're going to be taking what we've built with our informatics and our care transformation model, and we'll be rolling that out to the North Carolina market. We don't believe that our purpose is to grow networks. Everybody else is in the network growing business. But what we'd like to do as we're inventing this is have the tools available for all physicians and provider groups for the coalition of the willing that are out there to move forward. So in the first quarter of 2013, there may be a CHESS development person coming to talk to you. So thank you very much. This is the final part of my presentation.